Good afternoon. I would like to welcome everyone to come to this day of the UN Day of the Older People, International Day of Older People, and we have a nice program, I hope, for you today. I'd like to, first of all, also welcome everyone. We have a wonderful turn-up from. Thank you very much for coming today. And I would also like to welcome our distinguished panel. And we have, first of all, our ambassador here from Chile, Ambassador Serrazzi. Then we have Ambassador Ken Okaniwa, who will be joining us later because he had another appointment, but he will be joining us at 1 o'clock, and he's the Deputy Permanent Representative from the Mission of Japan. We have Ms. Odette Fudral, who is representing retired civil servants, let me put it like that. And we will have Kate Gilmore, who is about to arrive. Oh, there she is. Wonderful. The Deputy High Commissioner for Human Rights. And we have from within WHO, Dr. Yamamoto, our Assistant Director General for Healthier Populations, Dr. Ren, our Assistant Director General for Communicable and Non-Communicable Diseases, and Dr. Swaminathan, our Chief Scientist. So having said that, our Director General wanted to be here today, but unfortunately he was not able to make it due to other appointments, and we have a message from him to kick off this celebration of the UN International Day of Older People.
Excellencies, distinguished guests, dear colleagues and friends, populations around the world are aging rapidly. All countries must adapt quickly to this challenge. Health and social services are often fragmented or poorly suited to the needs and preferences of older people. WHO's new guidance tools for integrated care for older people, ICOPE, are a timely and valuable resource to assist primary care workers in caring for older people. ICOPE promotes person-centered care and support for older people and their caregivers. It provides practical tools to prevent functional decline and social isolation so that the older people can keep doing the things that matter to them and age with dignity. The WHO ICOPE digital application will support countries to train their health and social care workers efficiently and rapidly. If implemented, ICOPE will move countries one step closer to universal health coverage and the Sustainable Development Goals. On this International Day of Older Persons, let's all embark on the journey to make societies a place for people of all ages. I thank you.
So thank you very much, Dr. Tedros. And I think Dr. Tedros has highlighted a few points. First of all, the theme of this year of the International Day of Older People is around the journey to age equality. And I think within the SDGs, we recognize that we cannot have equality unless all population groups are included, and that includes the older population group. So Dr. Tedros also highlighted universal health coverage and has given us a very bold agenda to take forward and to get an extra billion people on universal health coverage over the next 5 years, and has highlighted therefore also how the ICOPE tools can help us achieve that. But at the same time, it's not only about health services, it's also about social services, and it's about multi-sectoral collaboration. And I think when we look at healthy aging, we need to keep in mind that it's about multi-sectoral action as well. But Dr. Tedros, I think, has also highlighted one other point, and he always tells us that, you know, it is about our mindset, and we should change our mindset. And I think when we look at aging, it's important that we have also a more positive outlook towards aging, and that we don't have ageism, or we're not stuck in concepts of ageism. And so he mentioned that, we should look at aging with dignity. And therefore, we would like to celebrate this day. And what better than dance? Dance is something that keeps people young. It's particularly for the older population, make sure that there is coordination between what we hear, cognitive perception, as well with how we move, our locomotor functions. It also allows people to engage and remain socially active and engaged with other people. And so for that reason, we thought that we would start off this celebration today with a dance, which will be performed by Li Kexin, who is an intern at the moment at ITU. And she will perform a traditional Chinese dance for us, which symbolizes autumn. Over to Li Kexin. Thank you very much, Li Kexin, and I hope that at the age of 80 we'll all still be able to do this. So I would like to now go to the opening remarks by Dr. Yamamoto and to open and launch the ICOPE tools.
Oh, thank you very much. And thank you very much, all of you, to coming to this launching. And please don't expect me to dance Japanese traditional dance like ITU stuff. So please don't do that, please. And also, Tedros and Anshu, you have already mentioned about core element of this launching. But let me say a few words as an opening. Aging society, talk about aging society. Some country has already entered the super aging society. Some country is a little bit the speed of the relatively slow, but all over the world is now has the same trend to be going to face or has already faced the aging society. And aging people or their family has some needs and needs for the care and the services. It's like a specific needs, and also the needs is so diverse and different from each individuals. So these two will be help the all care providers to provide a quality care. But again, this is a new one, so we accumulate the all experiences and knowledges in this tool, but there are spaces to improve, I believe. So I really would like to ask all of you to work together to improve, to create a good quality of care. But not only the care itself, we need to reorient the society. So we need to create a good system for service and welfare services, but also the good society, including social determinants of health and for aging. So I hope with this launching, we can celebrate this and use it and implement it and improve it for the society, for the elderly people and their families. So thank you very much.
Thank you very much. So we would like to launch actually the 3 tools that we have. The first one is on implementation framework of ICOPE, which is a guidance for systems and services. We have a tool which is a handbook and is a guidance on person-centered assessment and pathways in primary health care. And actually, for this guidance document, we also have an app, and those who have not an Android phone can actually download it. So we're eager to know who's going to be the first person to download this app on their Android phone. The iOS system version will be available in the coming days. So if everyone could just hold it up as an official launch. And wonderful, thank you very much. So having said that, and now of course everyone is eager to know what is in these tools and in these guidance notes. And for that I would like to ask Dr. Islene Arajo de Carvalho from the Maternal Newborn Child Adolescent Health and Aging Department. The WHO has brought innovation to us, and we're really looking at the life course now and really looking at how different stages of life all link up and what its impact is also at the end on aging and older people. And she is going to present to us what the content is of the tools that we have just launched. Islene.
Thank you very much. I'm very honored to be here representing a team, more than 100 people who worked on developing these two in the last 2 years. So thank you for giving me the honor to be here to sharing the work of so many people.
And sorry, I would just like to say one thing which I forgot, is there's French translation available, and this is also broadcasted live. And so we have already a number of people which are following this online. Thank you.
And there is simultaneous launch now in India, also in Washington during the executive board of directors in PAHO, and also in Japan. I have to start here. Okay. So, universal health coverage is the way to achieve the Sustainable Development Goal number 3, that focus on health and well-being without considering the health and social care needs of ever-increasing number of older people, the SDG 3 will be impossible to achieve. WHO committed to two very important goals also, in addition to that. One is to prioritize work to drive public health impact in every country. Secondly, to achieve a global target of reducing care dependence in old age. When we set that target, member states came with the question, but how? How to reduce care dependence in old age? In 2015, WHO launched the first ever World Report on Aging and Health, which defines health aging as the process of developing, maintaining the functional ability that enables well-being in old age. This is a transformational approach. Why this is so transformational? Because we are shifting the focus from disease to functioning. As we age, we're going to have disease. But what matters for the person is to be able to do the things that we value. And what are the things that other people value? First, be able to meet our basic needs. Secondly, learn, grow, and making decisions. Be mobile, be able to move around. Build and maintain relationships, and to grow, to contribute, and to grow. In order to be able to do all the things, this all depends on one simple thing, that's health. As we age, our intrinsic capacity and our functional ability doesn't remain the same. It declines with increasing age. There is a period where we have high stable capacity. There is a second period where we're starting to decline, have a declining capacity, but still we are independent. And there is a third period where we have significant loss of capacity. We reach the point where we need help with activities of daily living. However, this opens an opportunity for public health interventions because we can act in different levels of decline of intrinsic capacity. And there are many things we can do to prevent the decline in intrinsic capacity, even slow, and also stop the progression. ICOPE focuses on the group who are declining in intrinsic capacity and aim to slow the transition between declining intrinsic capacity to care dependence in old age. And there are a few interventions that can be implemented in primary health care level and community settings that can achieve that. However, unfortunately, health systems are not prepared to address the health and social care needs of older people. When older people try to access health services, they are frequently faced with fragmented services too far from where they live, ageist attitude of healthcare workers, and also lack of interventions to optimize intrinsic capacity and functional ability. So integrated care of older people reflects a community-based approach that will help to reorient health and social services towards a more person-centered and coordinated model of care that supports optimizing functional ability for older people. How integrated care work? First, providing care at communities close where people live. Secondly, offer person-centered assessment and care plan shared with everyone involved, meaning that everyone in the health system has a role to play on addressing the health of older people. We are talking here about multidisciplinary teams. Third, all professionals should work together to maintain intrinsic capacity and functional ability. And the most important thing is to engage in community and support family caregivers. The bottom-up approach is very important. Community-based integrated care, that's all what ICOPE is about. So today we are launching the ICOPE package of tools to support the member states to implement this model. The first guidance is to health services and to help health services and system managers and how they can evaluate their country capacity to implement ICOPE and design an implementation plan. The handbook is for health professionals and primary health care settings at community level to learn how they can screen other people, assess their health and social care needs, and design a personalized care plan. ICOPE is also help health professionals to implement the clinical interventions across 6 critical conditions that are associated with the client's intrinsic capacity and functional ability. So one is depressive symptoms, limited mobility, malnutrition, visual impairment, hearing loss, and cognitive decline. We have in ICOPE interventions like multi-component exercise, oral supplemental nutrition, cognitive stimulation, cognitive training, screening for hearing loss, for visual impairment. All these interventions should be delivered in a package in an integrated way. And all these conditions, they have synergistic effects among themselves. By addressing under malnutrition, I'm actually having an effect in improving mobility. By addressing depressive symptoms, also I am preventing limitations in mobility and also preventing cognitive decline. By dealing with hearing loss, I will also have a positive effect in preventing cognitive decline. Now let's have a look at the app, because I believe this is all you are interested. The interactive app guides health and social care workers step by step through the process of screening other people at risk of care dependence in the community, undertaking a person-centered assessment of all the people's health and social care needs, and design a personalized care plan. The app can also be used by governments and organizations to train health and social care workers to deliver personalized care. So the 3 steps, as I mentioned before, is screening, assessment, and design a care plan. Usually, we screen older people at risk of care dependence in the community. This screening can be done by a community health worker, can be done by a nurse, or even a caregiver. And it takes only 6 minutes. It has been already validated. Here you can see the screening for nutrition, for example. The people who are screened positive, they should be referred to a primary health care clinic to do a person-centered assessment. And usually the person-centered assessment should be done by a primary health care doctor, can be done also by a nurse. The app has all the assessment tests for the 6 priority conditions. After doing the functional tests, we can also see whether there is associated conditions. For example, in the example there, you see polypharmacy or delirium, etc. Based on the results, we design a personalized care plan in collaboration with the other person and also the caregiver. The app will prompt what are the main conditions that was found, and will lead the healthcare worker together with the other person to define the person-centered goal setting. That actually, the goal setting will not be treated this condition or that, will be around something that is important for all the people. Be able to walk in the wedding of my daughter, for example. After defining the goal setting, the app will show, based on the clinical tests, all the interventions should be included in the care plan. And this will guide a conversation between the health professional and the other person and the caregiver about how these interventions they can be implemented at home, in a rehabilitation center, on the private healthcare facility. The final personalized care plan can be downloaded, can be printed, and can be shared with the other person, with the other health professionals, but also with also the caregiver involved. And a follow-up will be done afterwards. The app doesn't have only interventions on disease or conditions. We have also care pathway for social care and support. All the algorithms within the app, they are evidence-based. The interventions, they are approved by Guideline Development Group of WHO. And that's what the app does. They put the algorithm together in a digital way and then give the interventions that should be in the care plan. In addition to clinical interventions, we have also care pathways for social care and support. For example, we look at whether the older person has need for a personal assistance, whether they need to modify the physical environment, or if they need assistive technologies, aids, adaptation, where the caregiver needs support. We look also at the issue of accommodation, whether there is need for home adaptation, whether the other person has problems with finance, and what can be done with relation to that. Whether the other person feels lonely. Loneliness is a very important issue to be addressed, and should be responses to lonely should be included also in the personalized care plan. And lastly, we look also for social engagement, where the person is able to pursue leisure interests, hobbies, work, volunteering, support the family, and what a community can do to support the social engagement of other people and remove barriers for their participation. We assess subjectively the risk of elder abuse as well. The way forward. Now we have the tools. We need to pilot the tools in a few countries. And you see these two offer, and especially using the digital health intervention, offer a huge opportunities to have digital data in critical conditions that affect other people, in prevalence of cognitive decline, in prevalence of mobility impairment, in prevalence of hearing loss in other people, and malnutrition in other people. Usually data we don't collect, data which health information system usually doesn't collect. It's called data on intrinsic capacity and functional ability of the people. However, there are many things we need to learn, we need to know. And one thing we are learning is looking at modeling and validating the use of this app and look at different scale-up scenarios to successfully implement ICOPE in different health systems. So we have to see issues like data analytics, data interoperability, develop predictive models that can help the implementation in the future. So pilots will go on in 10 countries, and there are many other countries already implementing ICOPE. ICOPE has been translated in French and Spanish, in Vietnamese, and Chinese, and Russian, and all without even our involvement, spontaneously by different ministries of health. There is a lot, as I said from the beginning, a huge amount of experts involved in development of these tools. I was just also want to mention the WHO Clinical Consortium on Health Aging. Thank you very much for your attention.
Thank you very much, Islaine. And I would first like to welcome the ambassador from the Permanent Mission of Japan, Your Excellency Ken Okaniwa, for joining us. Thank you very much for coming. And Islaine has been working on this package of tools for the last 2 to 3 years. But of course, she has not done this on her own. First of all, I would like to recognize that it was under the leadership of John Beard, who was the director of the previous Department of Life Course and Aging. There. Thanks for coming, John. And of course, there have been many other players. If I could just have the slide back.
Could you put the previous slide, please?
There were many other partners who have contributed to this. So we had a core writing team, but at the same time, we had 30 academic institutions across 15 countries that participated in contributing to the development of the tool. We had an internal working group across several departments in WHO. We had more than 50 aging experts of the clinical consortium that Islaine just referred to. We had a couple of collaborating centers that collaborated, and we had universal doctors that actually helped us develop this app. And all this was graciously possible by the support of our partners from Japan, Germany, and the Kanagawa prefecture from Japan. So thank you very much. We will move over to the panel session, and I would like to ask Ambassador Carla Sirassi to say something about how the ICOPE could be used in your context. First of all, we know that Chile has taken a lot of leadership around the agenda of aging. We know that nationally it sits very high in government, it sits in the President's office. We know that you chaired or you organized a side event at the UN General Assembly last year. You were one of the co-sponsors for the UN Decade presentation this year at the World Health Assembly. So thank you very much for taking on that prominent role. And so we would really like to hear from you, having listened to Islene explain what ICOPE is, or integrated care of older people, how you think in Chile you could use this and how you could implement this.
Thank you for inviting our mission to participate in this very important commemoration. It's really an honor and privilege for our mission to be here today with this distinguished panel of panelists. Like many other countries, Chile has experienced the effects of demographic change. However, we could mention that this rate has never seen before. For example, in 1980, we had 5% of the population over 60 years old. Today, we have 16.2%, and it has been projected that in 2035, the number will increase to 25%. Today, our life expectancy is 82.5 years old at birth. Due to the increase in all the population, the government of Chile has adopted a multi-sectoral approach plan. So several ministries and the National Service for Older Persons, SENAMA, are working under the leadership of the First Lady of Chile, Mrs. Cecilia Morel, who has advocated extensively for positive and healthy aging. And also an important role has civil society in our country. We believe ICOPE is very important. How can it be implemented? We could mention that first, we believe that can be implemented within two dimensions. The first one is based on community centers and clubs for the elderly. We look forward to also implement to take control of your health program, which is done in coordination with PAHO, to generate health-empowered seniors who know ICOPE and senior community leaders who replicate the training at clubs and centers. If the evaluation reveals that there's an intrinsic capacity loss, it will refer to primary health care. So second, the primary care, rural and urban settings, is the second area we have identified. Why? Because primary health care represents the first point of contact for individuals, for family, for communities, with the public health system, providing outpatient care. These centers are mostly managed by municipalities. We consider it is essential to train primary care professionals on the use of ICOPE, so it is used in the same way as the elderly preventive medicine examination, PAM, which is currently used in Chile and incorporates a set of evaluation guidelines that are in line with ICOPE. Also, how we have moved, how we are aligning our services to implement ICOPE. Chile has adopted several initiatives to adapt its current systems. First, we are working to increase the number of age-friendly cities with the support of WHO. So right now, more than half of Chile's municipalities have made a commitment to ensure adequate environments for the persons. And those with greater development, we made situational diagnostics, so they're more local programmatic offers as well. Second, we are fostering a specialized human resource training line for the generation of cross-cutting competences in geriatrics and gerontology. We are also accessing specialists through the digital hospital geriatric cell that is intended to reduce geriatric syndromes, starting with polypharmacy. Also, through the National Support and Care System, local network managers will be empowered to deliver reliable information on the local programmatic offer to older persons. And on long-term care, the National Support and Care System provides caregivers with regular breaks, so through providing substitutes for them, so formal caregivers come completely free and provide those breaks for the regular caregivers. So how we are getting also advanced and getting ready for ICOPE. So a cross-sectoral working group was launched to be able to progressively implement ICOPE in more than 10 health services districts in Chile. Through technological applications, the knowledge of older persons will increase, we believe, regarding what they can do to have greater control of their health. And in the app health information, as you see, there is care training that will be also provided. In the mentioned districts, health benefits will be provided aimed at promoting autonomy through physical, cognitive, and nutritional information. Also, pilot projects will be implemented in senior pension centers, carrying out evaluations with ICOPE and case management in family health centers. So we want to finally mention that we're really honored to be part of a ICOPE pilot, and we are deeply convinced that an integrated care for older people approach is the best way to address our aging society challenges. Thank you.
Thank you very much. And we, of course, know that Chile also had a very successful program for early childhood development that was also multi-sectoral, whole of society, whole of government. So I'm confident that this will also be having positive results on when we look at older people. So you spoke about community and how to work at the community level, etc. I would like to move to our next speaker, Your Excellency, the Ambassador Ken Okaniwa from Japan. We know that Japan is, and we would like to learn the secrets, is one of the societies with that's known for longevity. And so if you have any tips for us, please. But at the same time, aging is very high on your agenda as well, and you have taken forward, let's say, to make sure that at the G20 meeting, aging is going to be on the agenda, and so again, there you have shown a lot of leadership. And on top of that, I think Japan is one of the countries that does a lot around innovation. And we also work together with the prefecture of Kanagawa, and they have a lot of innovations that they can share with us. So having said that, maybe you could explain a little bit how Japan developed its community-based integrated care, and how do you see this alignment with the ICOPE? How do you think that the ICOPE modules and tools can help you improve the lives of older people?
Thank you very much, and I'd like to express appreciation to WHO for your work on aging, healthy aging population. Aging societies is a global trend, but Japan is the country with the fastest pace of aging, partly a reflection of the fact that we have a very healthy population. The percentage of over 65-year-old is a little bit less than 30%. And this is a level which, according to forecast, it's a level which China will achieve in 15 years from now, and France will achieve in 40 years from now. We feel that ICOPE is an important tool to deal with the aging, healthy aging, and many of the elements of ICOPE reflects the policies and the approach that we take in Japan. In Japan, we have been dealing with this through a program that we have had for the last 15 years. This program basically is aiming at for people to be able to live in their current residential area, to lead their normal lives until the end, even if they are under severe conditions requiring care. The aim to achieve this kind of a community is 2025, when the current baby boomers in Japan, many of them reach the age of 75. Now, the focus of this program is more or less overlaps with the ICOPE. One is medical care, two is care, old people care, three is prevention, four is living environment, five is livelihood support. The basic approach is for community-based integrated care, because previously it was the family which took most of the burden of taking care of the elderly, but we feel that it is no longer feasible with the burden rising and also more women coming into the workforce. On these five items that I just mentioned, on the medical care, we are attaching more emphasis on home-based healthcare. And in order to have more effective healthcare at home, we are particularly attaching priority to coordination between old age care and medical care, because it is the old age care persons which are in daily, more or less daily contact with the old people, and so that they have the first detection of if something goes wrong. And we are also increasing the number of people who are working in both medical and care, because there is a need for more regular visits and checks. Secondly, on prevention, we attach importance to supporting the intrinsic capacity of the elderly. This is focusing not only on physical, but also on the mental aspect of health. And in addition to the traditional approaches, we are trying to have more social interaction of the elderly, among the elderly and also through other generations, by using existing facilities such as universities and other facilities. We also have attached importance to regular visits by nurses in order to detect various problems such as dementia for early treatment. On caregiving, we have gradually been shifting from attaching importance to home-based care from the traditional approach of using nursing homes. And we introduced the public care insurance system for the elderly in year 2000, so that there is support, public support for this. Three, on the livelihood support, we are promoting a lot of new activities. This is a relatively new area. We are attaching importance to supporting the elderly through activities of the volunteer. And the local governments are trying to support various new approaches, such as using vehicles which are used for transporting the elderly to care facilities in their free time, to use them to take elderly to go shopping, and so that they are able to do their own shopping. Also, we attach importance to comprehensive management of the various activities to support the elderly. So we introduced the community-based integrated support center, and also appointing care managers who look at all the types of support that are given, and that there should be more coordination, and also if there are issues, that will be dealt in a comprehensive manner. The last point regarding this is that we are promoting decentralization, and we let the villages or cities and the prefectural governments take the lead, because there are big differences between regions, and the issue of the elderly care is acute in the big cities because there is a huge increase. But then there are also the rural areas which have a depopulation issue, and they have a less number of elderly, but they also need care. The last point I want to mention is that the long-term challenges that we face is, one is the ensuring that we have adequate number of qualified nurses and caregivers. This is partly to do with the issue of depopulation of Japan, and also training. Another big issue is the financing. Today in Japan, the Japanese government just introduced a raise in the consumption tax from 8.5 to 10%. And this is a big step and primarily aimed at supporting the support to the elderly. And at this moment, the elderly in general, they have 10% is out-of-pocket funding. So that is my presentation, and my personally, I'm in Japanese. Oji-san is a old man, relatively old man like myself, and Oji-san is a very old man. So there is a big difference in Japanese between Oji-san and Oji-san. So my hope is that when I become Oji-san, that I will be taken care of adequately. Thank you very much.
Thank you very much, Ambassador, and thank you for sharing that policy change that you have made by increasing the tax, and I think that's something that maybe other countries can think about as well. I'd just like to jump the agenda a little bit. We had hoped that Dr. Swaminathan, our chief scientist, would have closed the event, but she has a plane to catch, and so we can't hold up the plane, unfortunately. So I'd like to ask Soumya to give a few reflections on what you have heard so far.
Thank you very much, Anshu. Good afternoon, colleagues, and really sorry to have interrupted the agenda. But I would like to thank both the ambassadors for really sharing very useful reflections and very practical ways in which these countries have responded to the need of a growing, aging population to keep them as useful and productive members of the community. One other example that I always recollect is my visit to Thailand. I went to some of the community centers last year and also saw the decentralized way in which primary health care is provided in that country. And a striking image for me was one in an urban area. The primary health center had special initiative for the older population living there, so that they could come in and spend several hours during the day doing activities. They were dancing. It was so lovely to see such graceful, the old people, really enjoying their dancing. They were cooking and also, learning more about nutrition and other kinds of activities. But also I saw that in a rural area at the community level, the community had come together to set up a daycare center for those who were either too old and had to be left alone, or with our people with other disabilities. And they had people who were trained in traditional physiotherapy and rehab methods, using indigenous low-cost tools for rehabilitation, really working there with the older people. So I think the engagement of both the community as well as local governments is critical. And this has to be also, I think, a bottom-up, as I think you also have shown in Chile. So I just wanted to say a few words about the science division, because I think the ICOPE tools that have been presented today are a very good example of the direction in which we want to move. So the science division, as you know, was created just a few months ago as part of the transformation and the DG's vision for WHO that's absolutely focused on the excellence in norms and standards. And part of what we're doing is to look at the way we do our guidelines and our normative materials, whether it's strategies or policy advice or guidelines, to make them, of course, technically very at the highest standard, but also relevant and responding to the needs of the end users, and available in a form in which it's easily usable. So traditionally, of course, we produce the booklets and the documents, and then we have the PDFs on our website. But I think ultimately this is the direction in which we want to go. So I want to congratulate Islene and her colleagues and all of the people in WHO who put this together, because they've made it so simple that a community health worker with some training and certainly health workers at the primary healthcare level can easily use these tools, at least to do the initial assessment of the functional capabilities of the older people. Of course, then it needs a chain of other staff. And as we know that physiotherapists and rehabilitation experts are always in short supply, and particularly in the rural areas. So this is something we'll have to think about when we talk about UHC and primary healthcare really being comprehensive, is to go beyond diagnosis and treatment and really look at rehabilitation, at, of course, prevention and health promotion as well. So the departments of digital health and innovation and the departments of the quality assurance of norms and standards are really working together now within the science division to see how we can disseminate our guidelines in formats like this, either as apps or other digital tools, which can enable health workers, even in remote areas, to avail of the WHO guidance and the WHO norms and use them for management of people. So there is, of course, no way in which digital tools can replace people, but they're a very good added tool for healthcare workers at different levels to be able to use, and also I think outreach for the community and the population as well. So one of the things also that we're looking at is to make the WHO guidance directed not only at ministries of health, which traditionally our audiences have been ministries of health, but also now directly talking to people, young people, adolescents, as well as the elderly, and therefore communicating our messages in such a way that it's useful for the general population as well. So I think this is definitely a pathfinder, and I hope that we will be able to have some learnings from this, especially from the pilot countries that we talked about, and I hope that there'll be a proper monitoring and evaluation built into the scale-up of these, even if it's pilot and done in a few districts, to really learn lessons and to be able to then guide other countries who want to expand this work. Thank you very much for this opportunity.
Thank you very much, Soumya. And I think that was the airline calling you. So I would like to move on to Ms. Odette Foudral, who represents former retired civil servants. In case you speak in French, we have bilingual translation. So for those who would like to follow it in French. And you also represent civil society globally, and you, of course, engage on a day-to-day basis with older people to represent them. And so we would like to ask you how you think, after the presentation on the ICOPE, how do you think integrated care can help older people from a day-to-day care perspective?
Oui, merci beaucoup de me donner la parole. En fait, je vais faire travailler les interprètes français, c'est bien, d'une certaine façon. Et surtout, je mets la barre de l'autre côté, c'est-à-dire du côté des retraités et du côté de notre perception de cette initiative. C'est vrai que moi, que j'ai eu le temps de feuilleter vraiment en détail toute cette documentation, et ça m'a beaucoup interpellée parce que je sais que la plupart du temps, les personnes âgées se plaignent essentiellement quand ils vont chez le médecin on leur dit, vous venez pourquoi? Vous renouvelez les médicaments, au revoir. Donc ils ont vraiment l'impression d'être pas suivis complètement. Et cette approche de tout regrouper, de trouver une solution, de savoir que tout est ensemble et que chaque chose peut avoir une interférence sur autre chose et quelque chose qui enfin nous fait comprendre que quand on devient de plus en plus âgé, tous les petits détails de la vie interfèrent les uns avec les autres, soit pour donner une meilleure vie, soit justement pour donner une vie pire. Et on a remarqué que, par exemple, quelqu'un qui ne voit pas bien, eh bien, non seulement il ne voit pas bien, mais il va être limité dans sa mobilité parce qu'il va avoir peur de sortir, de tomber. Il va être limité dans ses possibilités de s'intéresser au monde, donc il va tomber dans l'isolement parce qu'il ne peut plus lire, il ne peut plus regarder la télévision. Il va être aussi limité dans ses possibilités de sortie. Et puis, il va aussi être regardé un peu plus comme un vieux. Et ça, c'est aussi une sensation personnelle qui interfère qui peut donner lieu à la dépression et vraiment à un sentiment qu'on n'est plus utile dans la société. Donc vraiment, moi je salue cette approche qui peut, je l'espère, apporter beaucoup en centralisant l'approche de la personne et en focalisant d'abord sur la personne et non pas sur la maladie. Et c'est ça qui est une nouvelle approche que je salue, parce que jusqu'à présent, en tant que personne âgée, on a toujours le sentiment qu'on est de trop, qu'on gêne, qu'on coûte trop cher. Et je ne pense pas que si vraiment on prenait les choses dans leur ensemble pour traiter une personne qui a juste un bobo, mais que ça va après engendrer tout plein d'autres bobos, ça coûtera beaucoup moins cher, justement, parce qu'on va identifier la personne comme un être humain et pouvoir enfin avancer avec ces personnes. Malheureusement, ce que je crains, c'est que pour beaucoup de gouvernements, à mettre en place, ça sera très cher et ça risque d'être quelque chose qui va empêcher la mise en place. J'espère que non. Et j'espère que non parce que si vous partez du principe que tout sera disponible par les smartphones, on pourra peut-être passer au-delà du blocage du gouvernement pour aller directement aux personnes qui sont en contact avec les personnes âgées. Et ça peut être une bonne chose. D'autant plus que j'ai entendu qu'il y a déjà une version française. Donc ça, c'est bien. Parce qu'il faut pas... On se focalise toujours sur une seule langue, mais il y a des personnes âgées dans le monde entier, donc il faut penser mondial aussi. Merci.
Thank you very much. And so, having listened to Mrs. Voudral, everyone has the right to health, and no matter what their age is. And I think, Kate, you are an advocate of that, whether it's a child or an adolescent, a woman, or whether it's an older person. And so we would like you to reflect a little bit on the discussions that we have had and to maybe reflect a bit on how does integrated care for older people contribute to the enjoyment of human rights for older people.
Thank you very much, dear Anshu and Excellencies, colleagues. Ladies and gentlemen, it's a great honour to be here on behalf of the High Commissioner for Human Rights, who apologises sincerely that she couldn't join you in person, possibly apologises that it's me to whom you now have to listen. Nonetheless, I felt connected in the acknowledgements for this wonderful publication. I saw reference to ageing experts, and I thought, I feel I belong. At least I'm ageing. I don't know what my expertise is, but I was struck by what a human invitation this is, to enter into a human dialogue about that which touches us all. It is the one identity to which everyone aspires. It may not be our dream identity, but for sure, around the world, to live until such a time that one may be deemed aged is inherently the one shared aspiration we all have. But accompanying that is this deep desire to do so with dignity, to do so with respect, and to do so in a manner where we feel still inherently valued. And that's what this extraordinary asset is all about, converting that aspiration deep within us all into something that can be made practical and tangible benefit at community level via better policy, better investment, as we heard, and better tools. And we want to celebrate WHO's leadership on this and at this time in particular. Friends, it is an era in which principles, standards, the normative agenda, and fact are under great pressure. The role of the World Health Organization in reminding us that science is a friend to inclusive, effective, and sustainable solutions should not be undervalued. It is absolutely essential. There is a question of capability at the heart of the project that colleagues have articulated in the form of ICOPE. But it's not really the capability of older persons in the first instance. It is our lack of capability as policymakers, legislators, holders of public purse and deliverers of services. It has been our lack of capability to rise up to the great success of the development agenda post-World War II, which is that people are not dying at the same rates from preventable causes of mortality and morbidity, and people are living to be longer in their communities. This, for sure, is what every development agenda that has had humanity at its heart as opposed to economy has ever chosen to deliver to us. This is a fruit of success for which this place has played such a central role. But now, with the benefit of the largest generation ever of older people, for the first time, more people aged over 60 than children aged under 5, comes a new challenge of policy and practice, of budget and of legislation, for which there is a question of capability at hand. It's not a question of the capabilities of older people as much as of public policymakers. When you live in an era where it is said, as it has been said in the past week or two, when children are leaders and leaders act like children, you know the correlation between age and capability is imperfect. The correlation also between physical, chronological capability and mental capability is also imperfect. How are we to make our way through that? What the rights agenda says, as indeed the science agenda says, is that there must be upheld some universal principles. And for those who age over time to a point where we start to note and respond to diminished capability, we cannot at that turning point generalise to remove their humanity, any more than we can say to a child as their progressive capability takes them into greater autonomy, greater decision-making and greater participation, you have no rights. Rights endure. The Universal Declaration of Human Rights says, born we all are free and equal in rights. It doesn't say that is up until urinary incontinence. Rights endure. Rights are that which cannot be taken from us with legitimacy. And the lack of capability, the incompetence of our current public policy frameworks are shown in the ways those rights are not being upheld. In abuse, elder abuse, in institutional policies that demean and degrade, in discrimination, in age-based discrimination, and critically in locking out older people as actors in their own destinies, as agents of change, and as contributors to community. It is their right to be so in the same way as it is the right of the child to contribute to decisions affecting their life. Of course, it's about progressive and regressive capability. But the connection between capability and contribution is a rights-based connection. The connection between need and service is a rights-based connection. The connection between incapability and the care we all deserve and are entitled to is a rights-based connection. And it is why this important asset is such a central part of the promise we have made to universal health coverage, and it must be fully integrated, fully invested in, if older people are to be treated with the dignity from which no one can deprive or separate them. This is a challenge for the United Nations. Look at how we handle older people's needs, concerns and contributions in the context of climate change. Look at how we're handling older people in the context of humanitarian crisis. Look at what is happening to older people in an era when more people are displaced by conflict and crisis than since World War II. It is our lack of capability in this area that is being invited into uplift through this and through other assets. Let us be clear, though, that this great success of integrated and more humane development, person-centred development, that is now reflected in attention on older people, is a sign of great success. This is not a sign of a problem, it is a sign and evidence of an opportunity created by great success. But it is an opportunity that we can waste through failing to respond simply because we don't recognise it or it's too new. But human rights are guide rails as we go about implementing policies, tools, and assets such as WHO has created. And for that, we are enormously grateful and enormously proud to be in strong partnership with you, sir. And we thank you.
Thank you very much, Kate. And so we spoke about how to address capacities, but we also do know that, and it's part of the assessment, that older people can also have comorbidities. And so Dr. Ren, as the Assistant Director General for the Department for Communicable or the Division for Communicable and Non-Communicable Diseases, could you reflect a little bit on some of these comorbidities and how we can include them in the care in relation to care for older people?
Thank you very much, Anshu, and it's a great pleasure for me to be part of this panel discussion on these very important issues. As Kay said, because we're all moving to the aging population in the coming years or months, probably. But we have to remind ourselves, I think probably this launching is absolutely good timing, because we are here just a few days after UN high-level meeting on universal health coverage, which concludes with a landmark political declaration on universal health coverage, moving together to build a healthy world. In this declaration, the member states committed, among others, to scale up the efforts to promote healthy and active aging and to maintain and improve the quality of life and of elder people around the world. That's very strong commitment in the political declaration. Probably need to double check where this language is. But first of all, probably let me congratulate to the Easley and the teams to lead this very important work, which several disease programs in my division has fully engaged. I understand the Department of NCDs and the Department of Mental Health, Substance Use has contributed to this important work as well. I see this ICOPE tools are completely, entirely complement to and synergic to WHO existing guidelines on NCD and mental health. And if implemented together, I assume these tools will mutually reinforce each other. We look forward to continue this cross-department collaboration and rolling out these tools in the country. As people aged, we all know what the scenario is supposed to look like. Their health challenges multiply. They intend to have increasing restricted physical and mental health capacity, including declining ability in hearing and vision, reduced mobility, onset of various, often multiple NCDs, as well as mental health conditions, such as depression and dementia. And there are many hidden health conditions, probably that the elderly and their families may not be fully aware of. Yet the presence of this condition and impairments say little about this impact they may have on the elder people's life. High blood pressure may be easily controlled with medication in one elder people, while in others it may require multiple treatment, triggering significant side effect. Old peoples with age-related visual impairments may not be able to perform simple tasks like reading and seeing and watching movie without aid of glasses, but remain full function when using them. Since aging is associated with increasing risk of multiple mobility, as Anshu just mentioned, we need to consider the effect of all the possible conditions and impairments together. That is what's called a people-centered and integrated approach. Integrated care has been a fundamental principle for WHO work in non-communicable diseases and mental health, and in communicable disease as well. Health service integration is a critical component of a strong primary healthcare system, and it could lead to more holistic and person-centered care and better health outcomes. There is considerable work underway to explore how we can best achieve the integration in different settings. I believe these ICOPE tools can make very important contribution to this work. They also provide a much-needed framework for addressing some of the most fundamental issues around elderly health care. Population aging is considered to be one of the most significant social transformations of the 21st century. In order to address the challenges brought by these aging societies, countries around the world need to make significant adjustments in their health and social care system. Universal health coverage is about creating a new social contract between the government and society. Care for elderly and addressing the inequities that affect these age populations is a fundamental part of universal health coverage. As many people say, primary health care. Primary health care is a cornerstone of a sustainable health systems that can deliver universal health coverage. WHO issued a call for action last week in New York for all the government to invest additional 1% of their GDPs in strengthening primary health care, because we believe this is the truest way to move us closer to the world where everyone can enjoy their right to health. Investing in primary health care is an effective way to address the increasing burden of mobility, multiple health conditions, and the challenges of aging. It should be a catalyst for solving some of the most important demographic challenges in the health sector. So I thank you very much for your attention.
Thank you very much, Dr. Ren. And Monica, I must apologize because I think when I introduced the panel at the beginning, I was looking at my left and I forgot to look to my right, and I think I forgot to introduce you. So Monica Ferro, from the director of the UNFPA office here in Geneva, welcome, and thank you for joining us as well. And we know that women live longer, and in 2017 we had 61% of the population above 80 were actually women. So that's a big difference. We would have 39% versus 61%, so that's a big gap there. And would like to, from a UN Population Fund perspective, like to have some reflections from you on the meaning of population aging and the implication on gender issues.
Thank you, dear Anshul. Thank you so much for the invitation and for UNFPA to be here. And to make this short, I'm going to just compliment everyone, saying observing all protocols. But that's a very interesting question, and I think that it's in the core of the package that you've just developed. A lot has been said, and of course that we are fully aware that aging is really a triumph of development. That's very clear, and we should celebrate it. What's relevant for us also to highlight, it's a fundamental change in the age structure of countries. And as Kate has mentioned also, the proportion of older persons over 60 is increasing due to life expectancy and the improvement overall on our access to health. And we know that this will have an impact. The fact that 1 in 8 persons is currently aged 60 or older, and this is projected to increase 1 in 5 by 2050, the first year where we will have more older persons than children under the age of 15. What's very interesting and it's relevant to mention is that we focus a lot on these global trends, but they mask regional disparities. It's not the same worldwide. Well, we have 5% of Africans 60 years or older, slightly over 10% in Latin America and the Caribbean. Northern America, the number amounts to 21%, and Europe to 24%. Of course, that this calls our attention to data. We need to collect data to understand the type of population we have. And when we collect data, what we see is that older persons, they are either overlooked or they are treated as an homogeneous population. I'm sorry, the Portuguese here is not helping. While the needs, the vulnerabilities and capacities of old and the older persons they differ considerably, and you made the point when Iselin made the point when she introduced the package. And this is further compounded by the relativity of the notions of age, depending on the context. As we know, age is also a social construct, and this means that when we gather data, because we all know that we treasure what we measure, this has to be very clear when we are taking a deep dive. Of course, as we see that people live longer, even as family sizes become smaller, in some countries the main concern is about the sustainability of social security and the intergenerational support systems. As a growing proportion of older people rely on pensions, there is fear that this will exhaust government budgets and undermining economic growth. So there's a lot of myths to be deconstructed, and there's also a huge reflection to be taken. As you were saying, it's also a question of attitude. And there is also concern that in old age, existing inequality will be exacerbated. We all know that elderly men, they have higher incomes than women due to the fact they have higher incomes throughout their lifetime. And this is partially important because older people is and will remain predominantly female. As women outlive men, we are seeing more women left in poverty. This is also why we need to tackle the structural disadvantages and discrimination against older people, as it was mentioned. I know that time is running out. I'm just going to mention 2 examples when we talk about the particular focus on women or a gender lens when we look at aging. We know that often women go to medical centers, clinical centers, and they hear often the expression, "You're not sick, you're just old." This type of judgmental and non-human rights based. This has also to do with the lack of specific training throughout medical universities, and I think this is something that we need to put on top of the table. Often women don't denounce this discrimination because they've grown used to it throughout their lives, and this is very critical. Also, when it comes to older women, we often neglect that they are entitled and they need services and care on sexual and reproductive health. Old women still have sex, And all women have reproductive organs. So the fact that most of them are left out of many programs on cervical cancer screening, breast cancer screening, or the basic health prevention, the healthcare and prevention services, this means that they are often discontinued when you reach a certain age, and this will amount to further inequality, to further discriminations. And just to finalize, we often think of women also as caregivers. It's also a sort of socialization they have throughout their lives. But what we see is more complex healthcare providing becomes and healthcare services become, women, because they often didn't get the basic trainings, they're also not capable in coping with the new demands they have being brought on top of them, and not to mention, of course, the role of women in healthcare, in the healthcare workforce. And there would be a lot to be said, but if I can leave two messages: data. This is the critical entry point for UNFPA to provide demographic intelligence so that countries can be prepared for the upcoming demographic changes. And when you look at data, don't forget to put another pair of lenses, and that's the gender inequality lenses that you need to put when you are looking at this package. And I think that you're rightly done. Thank you, Anshu.
Thank you very much, Monica, and also for highlighting that point about data, because we do know that as part of the sustainable development goals, there's a strong focus on disaggregation of data between age and sex. But in many countries, data collection stops at the age of 65, 70, and we actually do not have data for people older than that. And that will make it very difficult for us to put the right policies in place, because we don't know what's happening. It's an invisible population, let's say, when it comes to data. So we do hope that our statistical organizations at national level will take this into consideration as part of their work around the Sustainable Development Goals. We have a few minutes left. Maybe I can indulge the audience, and maybe we can go over time for a few minutes in case there are we have a lot of member states, many member states here around the table, in case you would like to make an intervention, or some other partner who would be interested to make an intervention. So I'll open the floor for a couple of minutes, and depending on how many people would like to take the floor, we will close after a couple of minutes. I think everyone needs to run to other... Yes, there's a hand in the back, please.
Hi, I'm actually not a member state. I just wanted to indicate how much I appreciate the humor and passion with which all of the presenters talked about aging and investment in ensuring that people as they age have the appropriate interventions and good health. Along with that, I'd suggest that members consider investing in their health workforce to provide those interventions. I know that a lot of countries are doing that, and particularly as we look at community-based interventions, I wanted to highlight the availability of community health worker guidelines to support optimizing programs.
Thank you. If I don't see anyone... You have an announcement? Yes, please.
Yeah, I did appreciate all the interventions. I mean, it's things that I've been thinking and realizing myself for years. I've written an article on this, but my real question is that right now, in Europe, let's say, is there any kind of institution which considers integrated, personalized, new age approaches to elderly people and treats them like human beings, with different problems, with different constructions maybe. But is there any way, concretely speaking, a place where elderly people can go and find some response to their needs and some real dialogue about themselves and their aging problems or non-problems or whatever, I mean, the personality change or whatever. Is there a place that you can, is there a list of places that one can have? Institutes, national, international, I know there is nothing like that in Geneva. If there is one, it would be great, or in France, or in Germany, or... Thank you.
Thank you for your question. I'm also dreaming about that for myself in the future. And I must say, I'm dreaming for my father that actually needs integrated care. And although I've been so much involved in developing this program of integrated care, when finally my father needed it, I struggled myself to find a place. He lives in Brazil where I can offer this comprehensive care. There are many good examples everywhere. Well, I know there is in Yorkshire, there is a program that is actually implements ICOPE and integrated care. Person-centered is the most important aspect. Also, this was inspired by the experience in Canada with Prisma, and also the experience of Australia. But there is the perfect place yet to go, because I think it requires a big transformation, and the transformation from the heart. A transformation in how we understand aging and how, as human being, deals with the older person. As someone who's going to be old, or is already, because maybe I'm already older person, I'm already half of my life expectancy, so as a concept of WHO. So recognizing us as the older person as well, but also in this relationship in which there is no power dynamic, we together define what's the best possible goal together based on values and preference and the well-being of the person in front of us. So really a transformation, we want to do a human transformation, more important than transformation structures or transformation institutions, etc. But that, I think I would say, is the first step to get that, to this inspiration.
Thank you very much. So I think in that case we will close this session, and I think the several speakers have highlighted different things. Dr. Ren highlighted really how this links with comorbidities of other diseases. Dr. Yamamoto highlighted, the multisectoral approach, and with the launch of the UN Decade in coming months, we really hope to see how this can really be integrated into that, and also really the issue of ageism and how do we look at older people, the mindset change that we need to take into account in order to look at their rights and how to provide those services, how they remain valuable to community, how they keep engaging in community, intergenerational social interaction, etc. We had representation from Japan on how their community program works and the innovation that's done there. We heard from Chile how this is going to be taken forward and the attention given at the country. We had a passionate speech from Kate about the rights and why the rights are so important and why there needs to be a link between rights and policy, and that it's our responsibility to take change in policy forward in order to address these needs. And we heard from Odette about what older people struggle with and how this can really be a useful tool for them to take this forward, and the need to really integrate this at large scale, scale it up in order to make it available to everyone. And from Monica, of course, I almost forgot again to turn to the right. The whole issue of data, older people, gender, and the importance of that. So having said that, thank you very much for coming. I hope you enjoyed the session. I want to thank our upcoming dance star, Lee Kishin, once again, and I hope to see you soon again. Thank you very much.